So I know it's been a long day, and I don't want you to cheer this, but this is the last presentation coming up. So you've actually heard his voice coming from the darkness. Now you get to see him in the light. For our final presentation, I'd like to invite Owen Richfield to the stage, and he's going to talk about his ideas. Again, these are early stages, so he's going to talk about his vision for the living kidney, call to action, and the thoughts that he's had in organizing the colleagues that he's going to launch and who would be the founders of that project. So Owen, please join me on stage.
This is awesome. Appreciate it. Can you hear me? Yes, okay. My name is Owen Richfield. I'm a postdoctoral fellow at Yale. I just want to make sure. Okay, and I am going to be talking about ideas around virtual twin of the kidney, which I personally am very excited about. So I just wanted to give you a brief background on me so you get the context of where this information is coming from. I originally, I originally majored in mathematics at Tulane, and I stuck around there to do my PhD in bioinnovation. Essentially, it's biomedical engineering with an entrepreneurship component. I'm happy to talk about that after the talk. I did a summer internship with the FDA at CDRH, so I've met a lot of the modeling and simulation people there, and that's actually how I first learned about Dassault. My dissertation subject during my PhD was mathematical modeling of blood flow in the kidney. And I'm going to show a little bit of that data today with the goal of talking more, especially with individuals that talked about the eye, because I think there's a lot of connections there. And now I'm in a postdoctoral fellowship at Yale. And what I do is I've moved from the computer to the bench. So I work on drug delivery to the kidney. We're specifically looking at gene therapy. I also have worked with ex vivo perfused human kidneys. So essentially this is a system whereby we perfuse a non-transplantable human kidney at normothermic temperatures, which means that kidney wakes up and undergoes ischemia reperfusion injury, and we study that process. I also make mathematical models now. Primarily, I'm doing pharmacokinetic modeling. And I wanted to mention that this presentation is representative of my personal opinions and experience. It's not necessarily representative of Yale or my PI, Mark Salzman, although he is very excited about it. So I want to talk a little bit about kidney disease, because we've been throwing around statistics of different diseases and who is dealing with the burden of these diseases. This is a really big number, and it is completely true. Globally, 840 million people suffer from kidney disease. In the US, 13% of the population, that's 43 million people, suffer from chronic kidney disease. This is defined as a reduction in your filtration rate over time. The primary drivers are chronic diseases like hypertension and diabetes. And it increases your risk of mortality by 200%. If you have CKD, you live a very different life. Globally, 8 to 22% of all hospitalized patients will experience some degree of acute kidney injury. And Dr. Zaharian talked about this yesterday. Essentially, this is your filtration rate will be reduced acutely, and typically this is a result of nephrotoxicity from contrast agents or drugs, or hypoxia, so lack of oxygen in the kidney, and I'll talk a little bit more about that as we go. It increases your risk of mortality by, yes, that's 750% while you are in the hospital, and 200% within 1 year. And lastly, in the US, 786,000 people require dialysis, which means that you have no kidney function and you need to rely on a machine that does that work for you. That's 3 hours, 4 hours a session, 3 to 4 sessions a week. So I talk about this in terms of with this passion, because this world is a horrible world, and it is not experiencing the attention that I believe it personally, I believe it deserves. So The kidney, crucial yet overlooked. The typical thing that people think about when they think of the kidney is that the kidney filters wastes from the blood. Yes, that is true, but that's not the most important thing the kidney does. The kidney directly controls the amount of blood that you have at any given moment. It also controls the sodium, the potassium, the chloride, on and on in your blood at any given time. And finally, it controls the pH of your blood. Okay? Without your kidney, you are screwed. So what we think of as the kidney is mythical. It's a trash can. That's not what it is. It's an extremely highly precise device that is controlling every aspect of your physiology. As a result, kidney dysfunction taxes the entire body. Dialysis is a Band-Aid. Dialysis is not a life. If you know someone who lives on dialysis, they hate it. And the mental health problem is a crisis. And it's not accessible. The transplant is complex, both technically and ethically. We work in the transplant space at my lab at Yale, and there's a lot of very complex issues that come with that. There are few therapies, and by few I mean 2 therapies that are actually targeted at kidney disease. Everything else just addresses the symptoms. So the field of nephrology, kidney, needs more innovation, and my hope is that the virtual twin of the kidney can be part of that, if not the leader in that innovation. So I want to briefly talk about the anatomy and physiology of the kidney. How does the kidney work and how is it structured? First of all, gross anatomy. So this is a kidney. As you can see, it's shaped like a kidney bean. The arterial network brings blood into the kidney, magic happens, and then the blood leaves through the vein. Okay? The cortex and medulla, so the cortex is on the outside and the medulla is on the inside. The microanatomy of the kidney is the nephron. So the functional unit of the kidney is called the nephron. If you take a cross section and you look at the microstructures that are there, this is what you're going to see. So this is composed of a glomerulus. So this is the filter of the kidney. The blood comes into the glomerulus. It gets filtered here. That filtrate then goes through a long tubule that actually extends all the way from the cortex into the medulla and then back. So that's this dip here, and then is ultimately released as urine in the collecting duct system. So physiology, the 3 things I want to focus on first are glomerular filtration. Blood pressure pushes the fluid out of the glomerular capillary into the tubule. Tubular reabsorption, so your kidney is constantly filtering your blood. 99.9% of that fluid gets reclaimed. It goes back into your bloodstream. It's only the remnants of that fluid that ultimately become urine. So people think of the kidney as just a filter. That's not true. The kidney filters and then it reabsorbs in a very smart fashion. And finally, renal autoregulation is a process by which this vessel, the afferent arteriole, changes its diameter in order to control the filtration rate in the glomerulus. I will note that the eye also autoregulates, and so does the brain. And so let's talk a little bit about how we mathematically model the nephron. So this is a schematic that was developed by Anita Layton's group. They're big in kidney modeling, especially renal autoregulation. So again, to orient you here, the blood comes in through the afferent arteriole. It gets filtered at the glomerulus. The filtrate goes through this blue tubule here, and the remaining blood goes to the vasculature that wraps around this tubule. So you have a tubule and you have vasculature that are deeply intertwined and reacting with one another in a physiological manner. So this was a mathematical model of renal autoregulation that we developed. Essentially here what you're looking at is afferent arterial diameter, so in other words the inlet diameter, and then perfusion pressure. So you can imagine that if your blood pressure spikes, your kidney would say, okay, higher pressure, more filtration, and then boom, you pee more. No, that's not how it works. Your kidney actually will reduce in the afferent arterial diameter to maintain glomerular filtration rate at the same amount. And that process of renal autoregulation is what keeps you alive when your blood pressure goes down. And it's what keeps your kidneys safe when your blood pressure goes up. So now I want to focus in on the glomerulus, which is my personal passion. It's what I did for my PhD. This is what a glomerulus actually looks like. So the afferent arteriole brings blood in to this tortuous network of capillaries that are wrapped up into a ball, and then there's filtration that happens. The rest of the blood leaves through the efferent arteriole, the EA here, so AA. And so if you unwrap the glomerulus, this is actually what it looks like. So here what you see are 320 segments. Each of these represents a capillary. The capillaries are worked together in this network where the blood flows in from the top and flows out from the bottom. There's little arrows on each of those capillaries to say where the mathematical model that I developed for my PhD says the blood will go. And then the thickness of these vessels is proportional to the filtration rate. So what you can see is that actually even within a single glomerulus, the filtration rate is heterogeneous across this network. We also did mechanical analyses, so we were looking at strain. In this case, now what you're seeing, these vessel thicknesses are proportional to the strain on those vessels. When that blood comes in, that's a pressure pulse that actually causes the glomerulus to stretch. And the glomerulus is stretchy, and we're thinking that this might actually involve, this might actually be a mechanism of pathophysiology in the kidney. So now let's talk about the virtual twin of the kidney. So far, what I've really been talking about is I've been talking about a nephron and modeling a single nephron. But in reality, the kidney has hundreds of thousands of nephrons that are all in close association anatomically. The ideal virtual twin of the kidney would somehow model this. It also would have to recapitulate physiology, that would be vascular and tubular, and I would be very interested in a model that can quantitatively represent pathology. So what is, I believe, required is an interplay of anatomy, physiology, and pathology. Because in reality, anatomy impacts pathology, anatomy impacts physiology, pathology alters physiology. And so ultimately, this is sort of the way I see the kidney, is that you need all three of these pieces working in parallel, working together. I think this is the secret recipe, if you will, for making a good virtual twin of the kidney. So practical problems, okay? First of all, chronic kidney disease. If you have chronic kidney disease, what you are typically doing is you are treating hypertension or diabetes. And many of these drugs act in the kidney. So if we could optimize these therapeutic regimens, that would be huge for a massive population across the world. Acute kidney injury, we can predict the risk of AKI, and actually Dr. Zaharian talked about that earlier. During surgery or critical care, there's lots of cases with AKI. I'm personally very, very passionate about AKI. I'll talk about it all day. Kidney transplant, so understanding, being able to predict graft function, risk of rejection, optimize immunosuppressive regimens, this is huge. The transplant community would greatly benefit from anything we can do in this regard. And then lastly, polycystic kidney disease. So polycystic kidney disease is the most common monogenic disorder. It means that there's one gene that gets messed up, and it turns your kidney into this. So what happens is cysts grow inside your kidney to the point where your kidney loses function, and in fact, people end up having back problems. Literally, their kidneys are so large that they have to be removed in order to walk properly. This is a heinous disease. And being able to have a three-dimensional model that can say the cyst growth is going to happen at this rate, the functional outcomes, anything in this regard would greatly help this community. So some challenges to development, technical. Many nephrons means multi-scale complexity. Fundamental processes are difficult to attribute to the kidney alone. The pH of your body is not just dependent on your kidney, it's dependent on lots of different organs and tissues. As a result, if you want to successfully model this, you might have to model the whole patient. There's also the immune system involvement. Most kidney diseases, the immune system is crucial. Lastly, I'll say that this is healthy tissue, this is diseased kidney tissue. Can we model the difference? How would we do that, right? It's hard, it's complex. I don't necessarily have all the answers. The other issue, and I'll just sort of run through these, say that we're really, really concerned about having the right data from patients or even patient populations. The fact is, kidney data, and I'm happy to talk about this all day, is very sparse. And so we've talked about then in the wearables, that is continuous data. This, you're getting an estimated filtration rate once. That's all you got. And now you have to somehow make up a virtual twin for the patient. So finally, opportunities, okay? Taking a multidisciplinary approach, which I will say that when I met Steve Levine, the first thing I fell in love with about the Living Heart Project is how many people are involved. It's amazing. And I think the exact same thing has to happen with kidney. Artificial intelligence, we've heard about. Interpatient variability is going to be huge, especially in transplant when you're actually not just dealing with one patient, you're dealing with two, right? One organ, one patient. Also, drug delivery. So I work with Mark Salzman. He wrote the book on drug delivery. There's a lot of problems where we don't need a molecule. We need a delivery system for a molecule that we already have, okay? So how can we develop this for the kidney? And lastly, small problems, big impact. My dad has hypertension. My grandfather had hypertension. Can we optimize those therapeutic regimens? We don't need a full virtual twin to do that, right? But ultimately, we want to get to that place where we can do this in a very comprehensive manner. So I thank you all very much for listening, especially at the end of this whole session. And please get in touch with me. I love talking to everybody about the kidney, if you haven't noticed. And also connect with me on LinkedIn. Thank you all very much.
Thank you, Owen.
Thank you.
And I think you can all agree I couldn't have picked a better final presenter. Okay, we got 30 seconds. We got time for one question. Yep. I know you all want to go. Yep.
Just a quick question. Based on the definition that you shared with us at the beginning, how do you, and if you are willing to make a correlation with the Living Heart,
Yeah.
I think the beauty of the Living Heart, the team were able to define the right scale and to make the transition between these scales. But I noticed in your presentation, you basically came up with two scales.
Yeah.
It's going to be sufficient to cover the entire problem and to tackle the entire problem?
I think that if you want to address the whole problem, you will have to ultimately go to a system scale model of the body, and they have developed this. So the Robert Hester at University of Mississippi developed the HUMOD, and that is a cardiorenal model with a neural input, et cetera. So I think, and acid base as well. So if you really need to go there, I think there's ways to do that minimally. In terms of the scale of the kidney, it would be great to model a nephron and then be able to scale that to the whole organ. How you do that, the fact is, that's not my area. That's why I'm here, because Dassault knows how to do this kind of thing. Spatial organization of many different functional units interacting. So that's really why I love collaborating with these people that are here.
Yeah. Okay. Did you integrate the endocrine function of the kidney, which is the control of the system renin-angiotensin that is produced in the kidney?
Yeah, so the RAS is not something that I talked about. And really, the RAS, the renin-angiotensin system is practically the main target for all antihypertensive therapies. The kidney has its own renin-angiotensin system, and it all interacts within, and then the body has a separate renin-angiotensin system, and those interact. So absolutely, I think that's crucial, because that just gives us the first use case, is how can we accurately modify the RAS in order to best treat hypertension. And in Anita Layton's group and also Melissa Hallow's group, they're both looking at that problem. The other is SGLT2 inhibitors, which are huge for diabetes, and that now they're finding that's one of the two kidney drugs, is they'll just prescribe SGLT2. They don't even know how it helps the kidney, but they're prescribing it. So so I think RAS, and and the glucose system in general, glucose insulin. Thank you all very much.
Okay.
Thanks so much, Steve.
Okay.
Appreciate it.
Looking forward to it.